my name is Dr. Kumar Doctor. I am from Mumbai. And today we also have a keynote address here. I'm surprised it's not mentioned, but I know that it's there. Valdemar Prefer, he's going to talk about intrascleral IOL fixation. So we have first speaker who is Dr. Samresh Srivastav. I think he's one of the best surgeons. He's from Jaipur. Very, very knowledgeable, is always updated in the latest that's happening. Brilliant knowledge on artificial intelligence, and it's a pleasure to have him with us. He's also in our instruction course in the AIOS this year. So thank you, Samresh, and as you have to go to the other hall, I want you to speak, and he'll talk about complications and various steps, which is in cataract management. So this whole instruction course basically was when we are operating, something suddenly happens. And the thing next is, what do you do? You know, some doctors panic, and there are various things in various steps that can happen, either incision, CCC, phacoemulsification, anytime. So if something suddenly happens, then what next to do to save a complication or it from getting worse was the idea of getting this instruction course in. Over to Samresh.
Thanks a lot, Dr. Kumar. So I think it's the conferences like this where you can openly share your complications and not feel bad about it, because it's important for all of us to learn from each other. But before it all, I would invite you all to the 37th APACRS. We did the last Asia Pacific, a truly international meeting in Jaipur more than a decade ago, and this is the second time in India we are doing the Asia Pacific Academy in Ahmedabad, 21st to 23rd August, and I would invite you all to come and join us for this. I'm going to discuss the case of a standard grade 3 cataract, age-related. We've done one eye, flax with an enhanced depth of focus lens, and the other eye is planned. Since the patient opted for a femto, that's what we did, went ahead and did. Femto gives us a lot of convenience of shaping the capsular axis right, making the right kind of incisions, and so on and so forth, very comfortably. Notice we've done rexis and incision, but not chops in this case. So this is how the profile looks. I'm just trying to open up the incision to show you that the incision that we are doing is a trapezoidal incision, which means it's internally flared, but externally it's 2.2 millimeters, and it's a smoothly opening incision. Surgery was uneventful, and we are now implanting an EDOF lens. Again, implantation in today's date and time through a wound-assisted delivery is no complication at all, and our preferred technique for removing viscoelastic is to use a bimanual IA with irrigation underneath and an aspiration over. So that's, reasonably, in all reasonable sense, dialing the IOL in place, it looks like a well-done surgery, and one would not be expecting too much at the end of the procedure, and so the patient should be comfortable. But when the patient does turn on the first post-op day, this is what he looks like. And then nothing during the surgery happened that made us worry about this coming up on the first post-op day. So definitely there is something. And imaging always tells us what the eyes can't see. And there's a pretty big decimage detachment hanging around, which never really what first factored in or was evident when the surgery was being done. Again, same area showing epithelial and corneal thickness. And it almost extended centrally, except sparing the visual axis. Now at this point in time, if you notice the incision is well opposed, and it's starting from the incision side only, main incision side only. We said let's wait, because sometimes these decimates will automatically disappear, and once the endothelium pump picks up, they automatically start adhering and they go back to normal. But at 1 week also, the detachment, the patient's blurring was there, and in fact the epithelial thickness and the pachymetry even worsened. Same thing persisted for 2 weeks, and this is when the patient came to my knowledge that this is what is happening, and the edema had almost come centrally. So this is the picture at the end of 2 weeks, and you can see that alligator pattern sort of bringing it up. So we decided that enough is enough, and now that the senior consultants came to know, to go ahead and inject something. I like to inject air over any gas or C3F8 because there is a high possibility for increasing the pressure. And the idea is to inject opposite from the site of the decimate detachment. So notice how I'm getting in from the opposite side and using a stab incision with a 30 gauge needle. I'm not opening up the old paracentesis, but it's a straight stab incision and doing a nearly complete fill of air. The good thing about air is that you can do a nearly complete fill and you cannot worry about it expanding anymore. And the air will get absorbed pretty fast. So it does the job and it goes away. This is at the end of 2 days, the patient, almost half the bubble is already gone, but you can see the cornea is starting to clear up and the edematous pattern starting to go off. 4 days following, a surprising, miraculous clearing up of the cornea and the air bubbles pretty much gone. And this is how the patient looks finally at the glass appointment time, 3 weeks after the air bubble injection. There is a certain amount of scarring, but the central cornea is clear and the patient is finally comfortable. So it goes on to say that, when you have a problem like this, use imaging. Now this is another patient, similar situation, uneventful surgery, post-op day 1, and look at the amount of corneal edema. It is limbus to limbus. And this is what the AIOS-OCT shows. It's a near total complete detachment of the Descemet's membrane. I wanted to notice what happens. Did you see that wave pass through? I'll show you again. When you're hydrating a side port, one of our fellows did an overzealous overhydration and caused the wave to literally cleave the Descemet's through and through all the way from limbus to limbus. That's the importance. That is probably what we also did in the previous case, as when we were hydroing the incision, we probably overhydroed that part and that caused the Descemet's to move off because it found a plane between both the layers. So important thing is to recognize it in time, and like we should have done, maybe injected a little more earlier. Now moving on from Descemet's detachment to another patient where we are doing a cataract, again straightforward profile, and this is just about a week back, and I'm operating this patient. I have observers in the OT and I'm trying to show them a classical stop and chop technique. So so I've done a nice good trenching. I'm showing them the depth of implantation, and I like to work on lower parameters. So I'm keeping my flow rates low, my IOP controlled, and there I do my first chop. I'm trying to show a variation between a horizontal and a vertical chop, and it's a fairly clean chop. The hydro is well, so the lens is rotating in its place. And when I'm on the show off mode, I like to make at least 7, 8, chops so that it gets the technique showing. And the surgery is going on very well so far. It's a grade 3 nuclear sclerosis case. So I'm just going to move on ahead of this. Let's see. Yeah. So, but when I was removing the quadrant, I noticed in hindsight that there is a zone of clearing, which honestly I never noticed while I was doing the surgery. But when I show you the complication, I realize now that there is a zone of extreme clearing. And so whenever you see something that's so much more clearer than it should be, look out for trouble, but I did not. So I went ahead and I'm continuing my phacoemulsification, and notice this is the zone that I'm talking about, where there is a pretty much clear area of cortex over there. So I go ahead and take out the last bit. The good part about using machines that have good fluidics is that you don't have to worry about chamber instability even in the last fragment. So there's no need to put a spatula down or look for this. But again, because I had not noticed, I yanked out my instrument. Something I should not have done. If I had recognized the problem in time, I should not have pulled out the phacoprobe like that, but I'm oblivious to it even now. And you can see here this whole area of clearing. But what dawns upon is when I'm doing a bimanual IA, this is when it occurs to me that there is a zone of clearing. And now if you notice, you can also see some material. There are some epinuclear nuclear debris which has gone down from this area of PCR that has happened and gone on in the anterior vitreous face, or maybe in the anterior part of the vitreous body. When you realize that something has gone wrong and this is the problem, the first thing is to identify how much you screwed up with the anatomy. I'm injecting triamcinolone to see if there's any vitreous representation coming up. There's no vitreous that's coming up, and that's a good sign. But the problem is there is material still inside the eye, and some of it has gone posterior. This is also where a bimanual IA helps you, because bimanual divides the irrigation from the aspiration, and you can do a very controlled procedure. So I decide, since there's no vitreous in the eye right now in the anterior segment, to go ahead and first remove the residual cortex so I can secure whatever best I can before I decide my strategy for IOL implantation and maybe for tackling the posterior fragments that have gone down. I called my retina surgeon who was on standby now, and because maybe we'll need a 3-port pass planar vitrectomy. The key is now when you're doing something like this is to keep your parameters low. So I'm working at an IOP of 20, which is the lowest the machine can offer, and I'm using a flow rate of 14, 18, which means I have immense control. It's like driving a car in first gear slow, so that you know what potholes you can hit, and thereby you can stop when you can hit a pothole, and you can speed up when you don't. And notice I'm pulling out the cortex in the area of the PCR, but it's because of this slow fluidics that I have that kind of control, because I don't want to catch something I don't want to and make it even worse. Okay, so once we did this, before I remove my irrigation, notice I'm doing a viscoelastic exchange, because I now don't want my posterior capsule to move either anterior or posterior, because either of which can cause a problem. And for this I use a dispersive viscoelastic. And this is where we stand now. There's material here, there's material, if you can see over here, these nuclear fragments have gone behind, and that's the area of the PCR. One needs to tackle these nuclear materials, you can't just leave it like that. So I decided to do a pass planar. but a limbal and a pars plana approach, which means irrigation through the limbus and a vitrector through the pars plana. I'm using a 23 gauge trocar cannula system. Because it's an open eye under a topical anesthesia, I've given a topical sort of assembly on the local side, and my anesthetist on standby has given a mild sedation to the patient so they don't feel the pain of this entry. Once I do that, I go ahead and do a vitrectomy, and notice that I'll be able to clear off all the material that has gone posterior quite comfortably. And because I'm in the natural compartment of the vitreous, I'm unlikely to increase the PCR size. PCR edges look rounded, but if I were to pull it from the front, I would not be able to approach these nuclear fragments, and chances are I would have lost them. Once I cleared up this, now was the time for IOL implantation. So of the few choices that were there, was to put a 3-piece in the sulcus, I decided to go ahead and implant that EDOF toric lens in the patient's eye. And this is what I want you to notice. The amount of control that sometimes is needed is an experiential thing, but if you have a material that opens up slowly, an IOL that takes all the time, which is typically hydrophobic material, it gives you enough time to slowly unfold the lens, because I'm unfolding the lens, putting the leading haptic in the area of the PCR, and this is a toric lens. This is a trifocal toric lens. And then I'm even rotating it using a Varion image guided system into its desired axis. I did turn the globe left and right to see if I can lose it, and the chances are, if your PCR is large and you do a shoot inside, or you use an IOL that unfolds very fast, it can even open up the PCR and can go dip downwards. So once I implanted this, I hydrate the incisions with irrigation in place, because I don't want the chamber collapse and I don't want this to move anterior. If you're in doubt, take a suture like I did for these incisions, and this is how the patient looks 1 week following the surgery. And if you can see in retroillumination, that area of PCR. And this is the patient's refraction, but the proof of the pudding is in tasting it. So it's surprising that, such a good visual outcome is sometimes not possible in despite the best surgery, and this is hardly any refraction, 0.12 with 0.5. Patient's doing okay macula-wise, and the patient's been seen by a retina surgeon and is doing well. So to conclude my talk, whenever in doubt, it's always better to visualize, use techniques to visualize, and like in the case of Descemet's detachment. And when you do land up with the PCR, all is not lost if you understand your fluidics and just step down and go slow. Chances are you'll be able to salvage the eye. Thank you.
So Samresh, that was fantastic. I want you to tell the audience that when you hydrate a wound, and you had a fantastic Descemet's, so where was the mistake you think the fellow made? And 2, this is also a fantastic video for youngsters, that you should learn this basic step of going pars plana. We are always scared as cataract surgeons that this is going to be damn tough. And this, I think, if we can manage very easily. And another good idea was to have your irrigation in the front. So you got your pressure from the front, the back you removed it, made it low, got your posterior pressure low, no more vitreous coming out, you took out the nucleus piece. So that, I think, was also a fantastic idea. So 2 quick pearls to the youngsters.
So to answer pearl 1, when we are hydrating our incisions, in the first one I did the mistake of overzealous hydration, maybe because I overinflated on the sides. But typically the problem is when you're doing it on the sides, and you don't do it at the wall, but go at the edge where the Descemet's is attached and it's open, and you push a wave through. So sometimes we all do Descemet's detachment. The problem is we don't notice it when we do it, because we are at the end and our adrenaline is at our pump, particularly in junior surgeons. Please look out for any wave that's passing through and stop there. And always a good idea to underhydrate first and under-irrigate the incision and see and look if it's holding on. To answer the second question of pars plana vitrectomy, as I see it, the damage is already done with the PCR. Whatever had to be done is done. If you make a pars plana entry and you don't have access to a trocar cannula, use an MVR knife, open the conjunctiva, so you can suture it back, because then you'll be able to salvage the eye. And the retina doctors, our colleagues, are extremely proficient, and they can go back, look up, indent, and if any break, they can always laser it off. The problem is we either don't do it or we don't refer to our retina colleagues. So there is nothing wrong in doing a pars plana approach so long as we follow it properly.
Thank you.
Thank you.
I now invite the Amitabh Bachchan of ophthalmology, Dr. Amar Agarwal, who all of you know is just not a brilliant surgeon, but a brilliant innovator, and that's what sets him apart. And I don't know, some of you know, he was voted the 2nd most popular ophthalmologist in the world. And that was phenomenal, Amar, and please take over.
Thank you very much, Kumar, first of all, for this lovely course which he holds every time in here, ASCR is everywhere. So let's see 2 cases. First case, pseudophakic bullous keratopathy, anterior chamber IOL inside. So I make my scleral flaps, as you can see here. Once I made my scleral flaps, I prefer to make a scleral tunnel incision because obviously that AC IOL has to come out. Now the cornea is so bad, so what I'm going to do is take off this bad epithelium there. Once it's there, I see slightly much better. I fixed fluid in the eye. Now what happens is, I make my flap, but I'm worrying that they are not exactly 180 degrees apart, so I'm just adjusting it, make my sclerotomies. Once that's done, I'll do my vitrectomy, which you're seeing me do just now. Now, once I've done my vitrectomy, I always go in and see the posterior segment, because I do not know if the previous surgeon has dropped a nucleus, IOL, anything inside, which can happen. Extend my incision. Now take out this IOL. This has got some 4 haptics inside, so we need to take them out very carefully, and the issue is they get sometimes stuck to the iris. You see there, it's stuck to the iridectomy there. Here again, I'm removing the second one. Once it has come out, it might come out broken also as it has come out here, but I still got 1 haptic inside the eye. So you can see there, 1 more haptic is there. Now still, the broken haptic removed. Now this last one is got stuck to the iris there, and I'm just slowly and carefully bringing it out. My fear is if I rip it too much and the iris rips, the bleed will happen. Little bit of bleed happened, not much, so it's okay. Anyway, so far so good. Done vitrectomy some more. Now the issue is I need to fix a lens in it. Obviously there's no capsule, so we use a glued IOL technique. I'm using it like a non-foldable IOL because I already have a large incision. Once 1 haptic is in, now I go in with a second haptic, do the handshake technique, transferring it from one hand to the other, and externalize. Now look, both haptics are out. See the amount of haptic externalized, it's a lot. There's no way this lens will dislocate or sublux. So now tuck it into the chariot's pocket. Once that's done, now I want to make the pupil smaller. This is a technique which is called the phototropioplasty, single pass phototropioplasty or SFT. So this is just the animation. If someone has not learnt it, please move into this, because all you do is 4 throws and that is game, set and match. So in this case, I want to make the pupil a bit smaller. Here you can see I'm making the pupil smaller, passing the needle from one end to the other, railroading it, bringing it out. You can see this is the single pass. Once that's done, I'll put it 4 times the loop. That is the single pass. Now it's 4 throw and pull on both ends, and that completes this case. Now once you have done that, then we can move on to the next phase of the surgery. Once the pupil is small, the advantage here is if any closed angle is there, it becomes open. Look, I'm also injecting air inside. Now I create the P-deck bubble. So this is the pre-descemet's endothelial keratoplasty, not dissect, not demec. The advantage here is I can use young donor eyes. The second big advantage is these P-deck grafts don't detach. In DMAX, you'll have at least 25 to 30%. In this, you have about 3% only. Now I put a trocar ACM, AC maintainer, got air inside. Now I remove the endothelium desmase complex. You remember how bad the bullous keratopathy was? Once that is removed, my next step is to do the injection of the P-deck graft. Just load it into the injector, inject it inside, unroll it, and fix it with air. Now let's see how this patient behaved once I have unrolled the graft. Here you can see I'm injecting air under the graft there, unrolling it, fixing it fully so that the graft is well centered. The advantage in P-deck, ladies and gentlemen, is it will also move exactly where you want it to, not like a DMEC graft. Apply the glue, seal everything down, and you can see how the case looks when completed. So let's see now at the end of the case how the patient looks. This is at the end of the case, the patient looking. Let's see the post-op pictures also for us to analyze how this patient has done. So this was the pre-op. 2 weeks post-op, vision improved to 636. 1 month post-op is 618 already, 6.9. And now you will see the final picture here, 3 months post-op, ladies and gentlemen, 20/20 vision. You can see the pre-op and the post-op. I'll show you one more case and then I'll give it to Kumar again to move into it. Now this particular patient was a top actor. He had come to me from Poland. And I don't know how he was acting with such a bad cornea, but look at the iris. It is so badly damaged. So now I know I have to fix the iris and also fix the PDEC graft. So I make a scleral groove. I'm taking off this epithelium. Now once I've taken off this epithelium, now you see slightly better. Now the technique which we started to fix an iodialysis is the trocar assisted iodialysis. So here you can see I'm fixing a trocar AC maintainer. I've got fluid in the eye. Now wherever the dialysis is, right opposite it, you fix another trocar. Look at the trocar, it's a blue color one, that means it's 25 gauge. Okay, so right opposite the dialysis, I'm fixing my trocar AC maintainer there. Once that trocar is fixed, I will use this to fix my dialysis. Now the method is, this is a modification of hangback technique by Michael Snyder, but the principle here is very simple. I'm going to now use a double-armed Prolene needle. So you pass the double-armed Prolene needle, it goes like that, goes through the iris, that iodialysis portion you can see there. Once it's done, from the other side, you can bring a 30 gauge needle from the sclera. Now railroad the two, okay? Once you have done that, bring it out. So this is the first arm of the double arm Prolene. Now same thing you will do on the other side using the second arm of the double arm Prolene. So here you can see the first one coming out. Now I go in and do the same for the second arm of the double arm Prolene. So you can see I'm passing this inside. Once that's inside, again I'll pass it through the iris there, trying to fix the iodialysis. Remember one thing, in such cases the dialysis is quite bad. It's not a small amount of dialysis. So you have to be realistic how much you can fix also. Here you can see I'm passing it again through that iris tissue. I'll again bring it out through the sclera, through the railroad technique which I just talked to you about. Now all you do is pull on both ends, and you pull both the sutures, this dialysis will start getting repaired. So this is the trocar assisted iodialysis technique. Look, I'm pulling on both ends and you can see the dialysis getting repaired. Remember one thing, when you start repairing a dialysis, obviously the pupil will get decentered. So here you can see I'm fixing the dialysis somewhere in another area, and the principle is, once that's done, I will now add a photopupillasty in it. So this is the twofold technique. In other words, I'm combining the trocar assisted iodialysis with the photopupillasty. Here you can see the remaining second portion of the iodialysis being repaired. So this is the second arm there. Again I'm pulling it inside and solving it fully there. Once the iodialysis is repaired, now let's move on whether I can repair the problem of the peripheral anterior synechia. You see that I'm trying to break the peripheral anterior synechia there, because when I do the photopupillasty, the closed angle will become open. So that's my game plan here. I'm trying to break it with a rod now. With the other hand, I'm trying to pull on it so that the peripheral anterior synechia are broken. But if you don't fix it with the photopupillasty, the synechia will form again. So here you can see now I'm passing the Prolene needle through the iris to create the photo effect there. Remember, now what am I trying to do? I'm trying to do a twofold technique. I just did the trocar assisted iodialysis. Now I'm combining it with the photopupillasty to do this twofold technique. So basically a twofold combines these two techniques there to get a better pupil. Once I have done that, you'll see the pupil coming back into shape comparatively better than what it was before. Remember, this patient has come to me all the way from Poland. He's one of the top actors there. I cannot go wrong, okay? Because obviously he's a big shot, there's no discussion on that, but also he's come from another country, so obviously I will have problems if he has to come back to me. So here you can see now I'm fixing this photopupillasty somewhere on that side. Important issues, look at the Purkinje image, it's on the iris. So at that stage you can take a vitrectomy probe and just enlarge the pupil to make it more centered. So help to make the centered pupil so that the Purkinje image P1 falls on the pupil center, and you can see that happening now. Once that's done, all I need to do is shift to air, because once I have air inside the eye, I can remove the endothelium desmase complex to do the PDEC graft. So here you can see I'm removing this endothelium desmase complex. Once everything is there, here you can see I'm preparing the PDEC bubble, PDEC graft prepared. I will now inject it inside, and let's see how this patient behaved at the end of the day. So that's what we did here in this case. The case I showed you just now was to show you the trocar-assisted iodialysis, followed by the photoreopuplasty, and also ending it with the PDEC technique. So here you can see the ending of this particular case, which I'm going to show you. I'm going to unroll this graft. Once the graft is unrolled, I have continuous air infusing inside. I will now unroll that edge of the graft also finally. Let's see how this patient behaved in a second there, and that's how the case looks when it is completed. This is the patient post-op day 3, 6/18, and you can see the patient vision has improved to 6/6 here. Preoperative hand movements to 6/6. I'd like to thank Kumar once again for this invitation, and I want to thank all of you once again for being here for this course. Thank you very much.
Any questions? Because I think Amar and both might leave the hall, so anyone wants to ask him. So I think you were the first doctor in the world to do PDEC, am I right?
That's correct.
So the idea
We did
was
this with the help of
given to
Harminder
you-
Dua.
I
have
know,
to give
so
credit to
you were
her.
discussing with him with
Yeah.
Dua, and then it struck you, why not you do it?
Yeah.
So just for the information of the house, he was actually the first surgeon in the world to do PDEC, which is now become a normal norm in corneal surgery. Congratulations to you and your team.
So one question, how long did it take for you to finish the surgery?
How many days?
But
You
this
should
would
ask
have,
how many days?
because this would have lasted easily 3 hours to 3-4 hours.
उतना तो क्या करूँगा?
This is amazing, sir.
Over to Dr. Chitra Ramamurthy, who also needs absolutely no introduction. The chairman of Eye Foundation, which is now spreading wings because of her son, who is doing such a brilliant job.
Why not us?
And she, all of you know, that did a fantastic job as the main person, chairman of the ARC, did so many shows on a regular basis, was unbelievable. Over to Chitra.
Thank you very much, Dr. Kumar, for this wonderful introduction and taking to this talk. And of course, the opportunity to be a part of this very esteemed course, which brings in huge numbers of people coming for it. So my due is to talk on managing a threatened nucleus drop. Now, that's a most calamitous condition which we do face in our cataract surgical theater. It could be an iatrogenic PCR which has got created by us, or it could be an eye which already has a pre-existing dehiscence as in a polar cataract, or a PC touch has occurred in a prior vitrectomy procedure. So the main key is how to avoid the drop nucleus from dropping further, and this can happen only if we keep our eyes open to pick up those telltale signs in the posterior capsule or a zonular rupture, which is imminently going to happen. It's also important to see the status of the vitreous, whether the vitreous is disturbed or not, whether we need to intervene to do a vitrectomy first or not. So for early recognition, the signs are there will be a sudden deepening of the anterior chamber, irregularly too. There would be a sudden expansion of the pupil, which is called the pupillary snap sign. There suddenly you could see an appearance of a red reflex somewhere in the periphery. Suddenly a nucleus which was nicely rotating no longer rotates, or there could be a little extra displacement of the nucleus and tilting of the pole of the nucleus, and suddenly you might see the nucleus is in the anterior vitreous face. So before I go on to show you the videos, what we need to do is decide whether we are going to do a phaco or an SICS, and that's based on the amount of nucleus which is remaining. If it's a small fragment, we could actually tamponade the vitreous and remove it with a phaco. But if the nucleus is large and dense and it is admixed with vitreous, or if it is a small pupil, or if there's a weak zonules, you would have to think a lot more. So let me run you through some videos. Here, this is a polar cataract, and I clearly know that I have to create just an adequately small rhexis, because this might become the platform for placing the lens if the PC gives way. As of now, there is no clarity about how intact the PC is. And then I go on to tent up the nucleus and do a lens capsule and do a gentle hydrodelineation. Maybe I was a little too vigorous. Keep watching. The nucleus suddenly comes forward, and look at the pupillary margin. That's pupillary snap sign. So I know I have a blowout of the posterior capsule somewhere, and the full nucleus is there, and I'm just not going to take any chance at the moment, and I decide to convert to an SICS wound, ensure that my inner opening is adequate because the entire nucleus is there, make a small nick on the rhexis because it was a smaller rhexis, just enlarge it adequately so that I'm able to topple the lens onto the anterior chamber and get it out smoothly at one go. I would have to suture my main port incision and then do a vitrectomy, ensuring that my IA is directed towards the corneal endothelium, not hydrating the vitreous, and then I place my 3-piece lens, but here I can't do an optic capture because I have already enlarged the rhexis. Now this is my second case. Again, a polar cataract, the rhexis is adequate, but I look at me, I'm doing a sideways sculpting because you can't rotate this nucleus. So this is one other way, but again I see a very clear red space, an unusual thing, and I know there's a dehiscence there, but I already have 4 pieces of nucleus which I have sculpted, and I get these pieces up. Probably this could have been done with an IOL scaffold, but in this particular case again, I wanted to bail myself out even more easily. And as the pieces were smaller, I just make a small temporal sclerocorneal tunnel, and then making my inner lip a little larger than the outer lip, I just get out all the pieces, and it's just coating the endothelium and keeping the anterior chamber deep enough. It is done in absolutely no time. That last piece is also out. Then I do an anterior vitrectomy, and once I've done a vitrectomy, I can see the ease with which I'm able to strip the cortex is a clear indicator that the vitrectomy has been adequately done. Of course, a tricot was injected and to see if there was any vitreous strands, but this was fine. There was a nice round rhexis. So the 3-piece IOL was placed in the sulcus, and you can see I've nudged at the edge to see there's an optic capture. Now in this particular case, half of the phaconucleus was out and half the heminucleus was there. There's a sudden shallowing of the anterior chamber. And again, I see that the nucleus is dipping into the vitreous, and at that moment, I go into the 2 side ports, and with the Simcoe's hook, I get the nucleus up into the anterior chamber. It was initially a 2.2 millimeter incision, so I enlarged the incision, and the plan of action here is to place my IOL scaffold. Now here, the vitreous disturbance is not adequate, so I'm able to visualize the area of the sulcus, and I'm positioning the haptic onto the sulcus right away at one go, and then I deepen the anterior chamber and enough coating of the corneal endothelium with viscoelastic, and very gently, carefully, repeatedly injecting viscoelastic, I get the errant nucleus out, and then I do a vitrectomy behind the IOL, and of course I see there's vitreous in front, and then do a vitrectomy in front. I would inject tricot, diluted tricot. This could have been even diluted more, 1:10 dilution, and then do a complete vitrectomy, and I get myself out of this case. Now this was another case where everything looked apparent at the slit lamp, and it was a dense cataract, and I've created a large enough rhexis, not too large. I follow all the dictums of the rule, a gentle hydro and decompression, and ensuring I rotate it so there's no stress on the zonules. But you know, I'm somehow not comfortable. First of all, my trenches were not deep enough, and I could do a sub-chop, but I feel that the lens is tilting. I'm just wondering, and then I decide, no, this is absolutely, the PC is open somewhere, I've gone wrong. So now I'm not able to visualize much. So I just lift up the nucleus, do just a gentle vitrectomy in that area of wound to get space to place my 3-piece IOL. Now initially the haptic was out in the wound, one of the trailing haptic, but then I ensure both the haptics are sitting on the iris and not on the sulcus because I can't visualize much, and then eat up the nucleus, inject tricot, do a vitrectomy, and position the haptic into the sulcus, and then complete the case. I would never chase a nucleus once I know it's gone into the anterior vitreous phase because the amount of traction on the retina is extremely hazardous. Now this is again another polar cataract. Now I do my hydrodelineation, and I sort of debulk the epinucleus, but suddenly I slow down. Like it was going at a fast rate. I normally don't operate that fast. But then I realized that some sinking thing is happening, so I immediately realized that the PCR has opened up. And I was lucky in this particular case that the epinucleus and the thing came out very easily. So I start removing it, and then do an anterior vitrectomy and removing the cortex. Then I see that small fragment of nucleus coming forward from the deep in the capsular fornis. But even before I realize it, it has gone into the vitreous. But I continue to do a complete vitrectomy, anterior vitrectomy, and then I tease out the cortex, and the ease with which I remove the cortex tells me that the vitrectomy is adequate. I polish the anterior capsule, and I make a suture in the main port. I do not hydrate the side ports. I take it to get the retina surgeon, remove it, then bring it back, and then here, there is adequate posterior capsule superiorly, inferiorly. So I inject my premium IOL, multifocal IOL, into the capsular bag. There's a central rip of the PC. So once I position the haptic in the capsular bag, I just nudge the optic so that I get it up onto the rexus, which is what you call as a reverse optic capture, and then secure the wound. Now, supposing it's a case of a PC, like you can see here, AIOS is telling me that the PC is not to be relied on. So I again stain the anterior lens capsule. I make an adequate size rectus. And here actually I see that this cataract is quite soft. I reduce the bottle height. And here I don't have to do much. I just aspirate with the IA itself. So I know there's an area of lens touch. There is an area with the PC, but you can clearly see it was just a small rent, and I placed the 3-piece IOL in the sulcus and got away. This was again another case of PC touch, and the arrow is telling you that's where the PC touch was. So, but then I know I have to go ahead and get the nucleus out. So I'm very ensure that I do a proper sized rexus, a complete rexus, a hydrodelineation, and endonucleus is prolapsed out. Then I do a viscodissection and I get the epinucleus out. These are the ways at which I would do it all the time, keeping my anterior chamber stable. And then I notice that area of lens touch. So, but yet the vitreous has not disturbed. So I go about doing the cortical wash and I place my 3-piece IOL on the sulcus, but there was a little forceful injection, and that area of PC touch opens up and all the silicone oil comes forward. I try to remove some of it, but I suture the wound, do an optic capture, and send it to the retina theater for the evacuation of the silicone oil. This again a case where there is evidence of lens touch, as was told by the surgeon, post-intravitreal injection. So herein, it's an intumescent cataract at that. So this rexus is so important. So I use the onion peel technique, slowly enlarge the rexus, because I know anytime this rexus could run away, and I just managed to get that adequate size rexus I need to deal with this moderately dense cataract. And the same techniques of hydrodelineation, because it's could be an open capsule. But what I find is when I'm gently making a little broad trench in the center before I start my chop, I find that the part of the endonucleus is coming up, like small flocculent fragments is coming up. So whatever comes up, I get it. So that essentially I'm debulking the central cord. So that gives me the advantage of doing a viscodissection. But yes, the ease with which this far things are going, I know it's an open capsule at some part, but the fact that the viscodissection is bringing up the epinucleus are indicators that the vitreous is not yet disturbed. So I keep doing a very gentle epinucleus removal. But here I feel there's a small clear reflex in that part, the inferior part, but still there's no vitreous disturbance. And I do a very slow aspiration of the cortex. And again, the ease with which the cortex is coming is still an indicator that the vitreous is still not disturbed and still the vitreous space is intact. So then I inject viscoelastic. I notice that there's a PCR there. By the time the PCR has become a little bigger, I position the IOL onto the sulcus, then inject tricort, do an anterior vitrectomy behind the IOL, and then finally do again an optic capture, which ensures that the IOL remains centered, and you don't have to change the power of the IOL if the IOL is centered. Thank you very much. These were just different ways which I tried to show you all to understand that even if there's a PC blowout, how you could manage your surgery, be it an IOS scaffold or an SICS or a gentle phacoemulsification. Thank you. Volume. Mic is not working.
Hello. Fantastic, Chitra. Professor Valdemir or Dr. Rohit Om Prakash, would you like to say anything?
I think with an open PC, the fluidics are the most important thing, and so is the chamber stability. By fluidics, what has been Vasavada et al. Have taught that with high fluidics, even an intact anterior hyaloid face can be broken. So one needs to work at a lower IOP, physiological, as Dr. Ramamurthy works at 30. I think that's the perfect thing which has to be taken into consideration. So, and you should never let because posterior capsule rupture is one thing and anterior hyaloid face getting broken is the second thing. So in our mindset, we have to differentiate between the two things. We have to create a situation wherein we can have an anterior posterior capsule rupture and still not have an anterior hyaloid phase rupture. And if we do not have an anterior hyaloid phase rupture, if we use low fluidics to our advantage, we can make the faux an ally. Faux means the anterior hyaloid phase or the posterior capsule, anterior hyaloid phase for that matter, as an ally. Yeah.
Please.
Yes, wonderful cases, thank you. I would just like to emphasize that when we have small pieces of a cortex, then we can use dry irrigation aspiration, or we can irrigate with the viscoelastic, with methyl cellulose, and aspirate at the same time bimanually. And this is very safe, not induce the hydration of the vitreous and preventing vitreous coming in front.
Thank you. Thank you very much, Kumar.
Any questions anybody would like to ask Professor Chitra? So I think there were fantastic cases, Chitra, at every stage, how to manage if there's a complication, because everybody is going to face it. For your information of the audience, that IOL scaffold was also an invention by Dr. Amar Agarwal. So all of us is implementing it, and it actually helps you to hold on to the nucleus in the front of preventing it from falling behind. Am I right?
Yeah.
So thank you very much. I need audio on this side, AV team. So this is OOOPS moments in cataract surgery, which actually went to the first level in All India this year.
OOOPS moments in cataract surgery, handling intraoperative surprises. These surprises can occur at every step of the surgery. Incisions, CCC, hydro, phaco, IA and IOL placement.
When there's something strange and the keratome slips, the capsule screams and the MVR hits. Who you gonna call? OOOPS Busters!
At times the keratome can slip and nick the anterior capsule. Solution to this is to start the rhexis from the same site and engulf the entire nick in the CCC to prevent a rhexis runoff. Such wound leaks can cause an unstable chamber. A simple technique is to take a sharp keratome and create another parallel incision in the roof of the original incision. Hydrate the same with the cannula and you'll be surprised to see that the wound leak stops.
We spin the needle and flap goes west. Down comes the news, giving us stress. Who you gonna call? OOOPS Busters!
An accidental puncture of the anterior capsule can happen while injecting the viscoelastic in the AC. Reform the chamber and start the CCC from the same site of the puncture, go all around and engulf the puncture site. An accidental puncture of the anterior capsule happens with the keratome. Form the chamber with the viscoelastic and start your CCC from the site of the puncture. It's important to go around and make sure the site of the puncture is completely covered. And this will ensure the CCC does not give way and the IOL centers in the bag. While performing rhexis with Utrata forceps, sometimes viscoelastic leaks. One must reform the anterior chamber, but re-attempting a rhexis will cause a leak and this can lead to a rhexis runaway. To prevent this, reform the anterior chamber and use a microrhexis forceps through the side port, go all around grasping the CCC to complete it.
A tiny rhexis, oh is that bad? Pop comes the sound, what the hell was that? Who you gonna call? OOOPS Busters!
When a small CCC is created, there is always the fear of a rhexis blowout during hydro procedures. In such cases, to perform in-the-bag phacoemulsification, reduce the bottle height, lower all parameters, observe the flap motility sign in phacoemulsification and in IA. Do not allow the chamber to collapse. Carefully inject the IOL, nudge it into the bag without dialing it to complete the case successfully.
The probe's at work, tricks up its sleeve. Don't go hunting, the water's deep. Taking a dive, it's time to weep. Who you gonna call? Oops, Busters!
In a soft cataract, there is a good chance there will be a crater formation. This leads to thinning and you can see a beautiful glow coming through. If the pupil is smaller than the size of the rhexis and there is a crater formation, we can use either hooks, viscodilation or continue struggling. The ideal choice would be to use hooks to get better exposure and perform safe phacoemulsification to prevent any complication. A case of weak zonules and a dense cataract, one can successfully complete the rhexis, but for a safe in-the-bag phacoemulsification, we have to lower all the parameters. But at times, the bag may tend to follow the nucleus and one can have a zonular dialysis. Of course, perform an anterior vitrectomy after staining the vitreous and insert an endocapsular ring from the area opposite to that of the zonular dialysis, followed by irrigation aspiration, which is tangential and not centripetal. This will release the cortex, which is entrapped by the endocapsular ring. This is followed by in-the-bag placement of the IOL. Make sure the IOL is not dialed all around and the haptics additionally support the area of the zonular dialysis. In another case during phacoemulsification, we face intraop meiosis. Even viscodilation does not help and the meiosis continues to worsen. In such scenarios, a ring can really help. But it is very important to make sure that the loop of the ring is not entrapping the CCC. We can release the trapped margin of the CCC from the loop before IOL implantation into the bag. The lens can then safely be placed into the bag. The ring which was placed can be easily removed.
The eye is tricky, CCC in shreds. Don't pull the tag, steer clear my friend. Who you gonna call? Oops, Buster!
During bimanual IA, misdirected fluid causes iris prolapse. So we reposit it, change our hands and direct the irrigation to correct the flow and prevent iris prolapse. This completes the IA successfully. In another case, while performing IA with a coaxial probe, one may accidentally hold the posterior capsule because the irrigation port is in the incision itself. In such scenarios, it may be wise to shift to a bimanual technique after IOL implantation to remove the subincisional cortex. In yet another case, while removing the viscoelastic from behind the IOL, the haptic can pop out from the bag into the anterior chamber. It can easily be put back into the bag under irrigation using Sinski hook.
It flippity flips and sometimes slips. Oops, oh no! The eye's in splits. Who you gonna call? Oops, Busters!
During IOL implantation, it may flip. Place viscoelastic to protect the posterior capsule and the cornea. One can flip this IOL and orient the haptics correctly. Then the superior haptic can be dialed into the bag. While inserting single-piece hydrophobic IOL, one would have seen stuck haptics, but this is something different. The haptic is actually held on by the body of the IOL itself. Nothing to worry, the haptic actually just releases itself and the IOL orients itself in the bag. In some cases, the haptic is trapped between the plunger and the cartridge itself. Don't be impatient. Cut the cartridge away from the haptic. This itself will release the haptic. Once the haptic is released, very simple, just dial it into the bag.
scream, shout, fear no more. Chin up, and soar. Who's got your back? Oops, Busters. So hold your wits and grace, 'cause in the end you'll find a place. Who's gonna fall? Oops, Busters. Who you gonna call? Oops, Busters. Who you gonna call? Oops, Busters. Who you gonna call? Oops, Busters.
Thank you. The idea here was to tell you that simple mistakes do happen, but we should not panic. And there is a solution which is quite simple many times, and your complication can be entirely averted. I'd like to invite Dr. Rohit Om Prakash, who is a fantastic team, has a huge hospitals from Amritsar, and organizes the winter IRSI on a regular basis. And this year he had 1,000 attendees plus in winter IRSI. Unbelievable surgeon, a fantastic innovator. The flap motility sign, which I showed in my video, is that if you have a tear going through till the equator, you don't know whether there's a wrap around and coming onto the PC. If you see the flap flutter, that means it's not gone around. If the flap doesn't flutter, that means your tear has gone around the equator and come to the PC. And Dr. Rohit Om Prakash is the inventor of the flap motility sign. Over to Dr. Rohit Om Prakash.
Inventor means I invented the anterior capsular tear. Yes.
Okay.
So thank you, Dr. Kumar, for the kind words. You're a very dear friend, and I feel an honor to be here. So I've been asked to speak in his IC on phaco after radial CCC tear, as he has already told. Well, anterior capsular tears can be a normal rhexis tear, or it can be an Argentinian flag sign. So why is it a surgical dilemma? Because at times we can complete phacoemulsification, whereas there are other times when we can end up with a catastrophe and we can have a nucleus drop. So what is the surgical plan? Well, the surgical plan lies in the fact that there should not be any panic mode. So relax, because there is a way out, and if not, we can always convert. But how do we, the first and foremost is that we evaluate the extent of the tear by the flap motility sign, and that is not the end of the story, that you're adopting the flap motility sign. Well, you have to use safe phacoemulsification techniques to back up your plan so that you can have a smooth sailing. So let's recapitulate this. If the flap, as he has already told, is fluttering and everted, this shows it's a pre-equatorial one. And if by any means it stops fluttering and becomes inverted and flat, it shows that it's a post-equatorial flap. So that is something which we should be absolutely clear of. Now, first evaluation is very important. What you should do is just inject the visco. And if the flap flutters, becomes everted, this shows it is pre-equatorial. So that is not the end of the story. You have to re-evaluate it. How do you re-evaluate it? You put in the phaco, put it on irrigation mode, and if it flutters, this shows it's a pre-equatorial and it's a green signal that you should go ahead. So how you should go ahead? Well, before talking about that, we should be able to evaluate the extent of the tear. How do we evaluate it? We can evaluate it ourselves. We can have our team trained. When we say intermittent, the surgeon intermittently sees because he's already stressed up. So there is little chance of his seeing again and again. But the OT staff, your doctors, they should be trained, who should be taking care of the evaluation of the tear extent by the flap motility continuously. And if by any means there is some reversal, it can be always taken care of. The surgical settings are very important. First of all, you should have calibrated incision so that there is no undue efflux from the side port. You should have active fluidics if you can. I don't have any financial interest whatsoever. Then you should use slow motion phacoemulsification, as has been showcased by Bob Osher and our own Abhay Vasavra. The basic concept is that we have to equal or minimize pressure difference between the anterior segment and the posterior segment. High settings, if they are used, they predispose to the anterior capsular tear becoming a wraparound tear and eventually causing a nucleus drop. And if by any means we are using low settings, the end point of the, the flap, that is not put under stress, and there is a less predisposition of that going across and becoming a wraparound tear. The IOP settings which I use usually in these cases is around 20 IOP pressure. So let's see the safe technique. So, first of all, the most important thing which you would realize that the site of incision. The site of incision is not in line with the rhexis tear. That is the first thing which, we have to bear in mind. Then, you have to do sculpting, and while doing sculpting, you should not be pushing. Look at the IOP settings which I'm using around 20. What is the direction of the separational forces? The direction of the separational forces are in the direction of the tear. So that is a very important thing because that puts less stress on the zonule, on the end of the anterior capsular tear. Rotation, if possible, should be avoided because at times that can cause a wraparound tear. Supracapsular emulsification should be done. So, and at the same time you will realize that with this low IOP setting, the flap is still fluttering. The chopping which is advisable, I am doing some bit of cross chopping because in this patient the nuclear fragment happened to be a smaller one, but ideally what is recommended is that you should be doing a horizontal chop. So, and now since this nuclear fragment happened to be a hard one, so I am using the chopper shield technique which we published way back to our advantage. See how I am placing the chopper. It is diligently placed anterior to the phaco-tip. Now when I am placing it anterior, it is protecting the corneal endothelium. I used stable chamber settings. The flaps at this point of time was fluttering and everted. This shows that it is a pre-equatorial one. So this assured that I could move around, continue the stable chamber settings again. Now once the IOL is implanted, as David Chang has taught us all around, that you should enlarge the rhexis. And one wrong thing which I did was that the positioning was not okay, which could have, now when I'm doing stromal hydration, there is some fluttering of the flap. So this is not the end of the story because we need to know, when should we convert. So we should know the end point of safe phacoemulsification, and obviously if the surgeon is not comfortable with, the detailing of the flap motility sign. So what is the end point of safe phacoemulsification? In this video you will find that the novice surgeon, in an attempt to enlarge the rhexis, created a situation in which there was an inadvertent anterior capsular extension. The sculpting was going on, and you will find that the flap is fluttering at this point of time. Now this showed that it was, now at this point of time, the flap stopped fluttering. Now the idea is, why did it stop fluttering? Because the separational forces were not okay, the high fluidics were there. So this is the point when the emulsification should have been stopped, and one should have converted to an SICS or ECC, whatever one is comfortable, because his continuing led to a situation where there was a nucleus drop. We have to avoid false positive flaps also. Now what is this? All 4 flaps should be everted and fluttering. So pre-existing PCR may coexist with fluttering everted flaps. I received a call from John Hart in US, and he said that there was a patient who had intravitreal injection and he did anterior segment OCT and the flap, and there was a PCR, and he somehow had an anterior capsular tear. The flap was fluttering, but there was a PCR, and since he knew that there was a PCR, he was able to retrieve it, otherwise it could have been a catastrophe. So pre-existing PCR may coexist with fluttering everted flaps. So, Dr. Kumar, should I continue? Yeah. So this is another patient wherein the patient has nucleus sclerosis grade 1. I showed it around in another IC also. Pupil size is 6.5. So she was continuing with the phacoemulsification. So what she did was she did hydrodissection, and after doing hydrodissection, she continued sculpting, and while sculpting she continued to go deep. She said that she was not able to focus, and lo, what has happened? There's a punch, posterior capsule punch. So she was oblivious of what was happening. Then suddenly she realized that something was wrong, and she was intelligent enough. She created stable chamber settings, called down to us, closed the case, and shifted the patient to the other OT. So this is something, which she was intelligent enough in doing. Now, what is the plan at this point of time? Should one convert? Should one use an IOL scaffold or continue phacoemulsification? So with low fluidics, as I've already told, to my advantage, so I thought I would continue with phacoemulsification because I knew that CCC was intact. I would be using low IOP to my advantage. I would not be rotating the nucleus and implant the IOL if possible, and change to IOL scaffold if required. So now what are the low IOP settings which I would be using? I would be using a physiological IOP of 18 to 22. 18 is not possible, so it would be 20 to 22. And this is what it is with different, in different steps. Or if I'm not comfortable, I can use the supraphysiological one, which I call between IOP 23 to 34. So now the patient was, got into my OT. So the sculpting was started. I was using low IOP settings. So I was very confident that with this low IOP settings, I would not be able to do any damage to the anterior hyaloid phase, as has been showed by Abhay Vasavra and his group. So I'll try to do the supracapsular emulsification. I was able to take it out because hydrodissection had already been done. So there were no strong capsulocortical adhesions. So emulsification was started. There was no pushing back of the nuclear fragment. The nuclear fragment was working, was floating in the anterior chamber rather than being pushed behind. Now I will try to pull out the other one. So the whole nuclear fragment is out now at this point of time. So emulsification is continuing at this point of time, and you will realize that now stable chamber settings again, which was being used. Then I retracted the sleeve because I wanted to create 2 levels of IA, and once that was done, so I would be using now dry aspiration, as has been shown by James P. Gills and Bob Welch from US in those extra capsular days. I use a 25 gauge cannula. I do IAFTS, irrigation, aspiration, fixing, teasing and stripping. So you will find that the size of the punch is the same as it was at the start of the surgery. I could have rounded it off and put in the IOL in the bag, but I just use the, put the IOL in the sulcus. So this is what I've already talked about. So thank you very much for your kind attention.
Fantastic, Rohit, as usual. Now invite Dr. Vardhaman, who is also a fantastic cataract refractive surgeon, massive practice in Pune. Over to Vardhaman.
Thank you very much, Dr. Kumar, and thank you for the kind invite to be part of your amazing course, which is always well attended with a lot of curiosity and many learning points for each and every one. So basically, no financial disclosures. I would like to also acknowledge contribution from my colleagues, Dr. Nidhi and Harshul as well. So friends, we all know that when it comes to the lens capsule, actually the lens capsule is the thickest basement membrane in our entire human body. But it is only 4 micron in thickness when it comes to the posterior pole. Prevention and the preparation for PCR is possibly the most important thing if it comes to the paramount optimal outcome for our phacoemulsification surgeries. And of course, these are kind of eyes where you should be already prepared that the patient may actually showcase a formation of PCR, such as this patient who has possibly a posterior polar cataract, patient with trauma, patient with intumescent cataracts, patient with extremely shallow AC, especially if you're not able to see the PC very well. And the studies have also seen that the PCR rate is also higher in patients who have pseudoexfoliation as well as high myopia. This is a fantastic study which has been published in ophthalmology. You can see that in the study of a large scale, 48,000 eyes, 1.8% eyes had actually encountered a PCR, and the most frequent occurrence occurred during the phacoemulsification itself, which was followed by irrigation and aspiration stages. So these are the stages where we have to be extremely careful. The risk factors for poor outcome, in spite of having PCR, you can have a very good outcome, but the poor outcomes can occur if the patient is very old, more than 65 years, if there is a dropped nuclei, if there is inadequate vitrectomy, which is the most important deciding factor for your post-operative outcomes, and of course, if you can avoid other complications. A missed PCR can cost you dearly. If you look at this surgical case, you will see that this lens is actually not rotating very easily, but there has been multiple, let's say, quadrant hydrodissection being tried, but the PC is not seen, the wave is not seen because the visualization of the PC is extremely poor. In this case, you can see that the lens is probably, you can watch, the lens is probably showing a small wobble. You can see that the surgeon is actually trying to do this into the stop and chop kind of technique, and now the groove is being deepened, but you can see there is a sudden shallowing of the pupil that you would have noticed here, and wow, now there is a complete nucleus drop. So if you are not able to recognize the PCR in time, this can actually cause devastating complications, and there can be fortunately very good signs that you can note, such as sudden pupillary bounce, constriction of pupil, which is also known as a pupillary snap sign. If you are unable to hold or chop the nucleus, which was being chopped very well, if the rotation is being very difficult because there is no counter traction from your posterior capsule, if there is a change of anterior chamber depth suddenly when you are doing a phacoemulsification or even when you are doing IA, if there is an inability to aspirate epinucleus, which you were able to do it before, but suddenly now there is a loss of efficiency of both phaco as well as IA, so this should actually preclude you and make you understand that there is something else happening, maybe something is occluding the tip apart from the cortex. Of course, there are certain obvious signs, such as if you have a picking of pupil, if there is a decentered lens which is not being centered very easily, and of course many times you can see fine lines on the posterior capsule itself. This pupillary snap sign is one of the most ominous signs if you want to actually know that there is a possibility of sudden breakout of the PC, as you can see here. And of course, if the rotation is being difficult, you actually have to understand that there is no counter traction, as we discussed. And if you are not able to aspirate the nucleus or the cortex, there can be a pre-evident PCR there. Of course, many times, as we have seen, if there are frank lines on the posterior capsule, this is a very, very, of course, obvious sign that you are dealing with an eye which has encountered a PCR. When you encounter a PCR, adequate removal of residual lens material and the vitreous is of paramount importance, and leaving behind as much as capsule so that you are able to support a lens implant. So what are the key points? Avoid a knee-jerk reaction, avoid abrupt pulling out of the phaco, make sure that you are actually maintaining the compartmentalization and also the pressure in the anterior chamber. Keep your foot pedal in the position 1, reduce your bottle height so that you are not, let's say, blowing out the PC even more, reduce the aspiration flow rate, and use the dispersive viscoelastic to create what is called as a compartmentalization. What is compartmentalization? If you see that there is a PC dehiscence here, the vitreous will try to come up, but if you use a dispersive viscoelastic and you clog or you plug the PC there, the vitreous will not come up, and then you can use even a HPMC or cohesive on the top of it so that you can do the rest of the procedure. Always make sure that you have your emergency kit with you, which should have the tricot, which should have a nice needle holder, a suture, a 3-piece lens in your library as always, and a viscoelastic which should be dispersive. So of course the next steps is to do a very thorough anterior vitrectomy without damaging the other parts of the eye and securing placed intraocular lens. What you have to understand here, when you are actually using a phaco pedal, it works very differently than when you actually want to do anterior vitrectomy. In anterior vitrectomy, you have to understand when you go to the position 1, of course it is going to be irrigation, but then you should go to the vitreous cutter, and that should be followed by the aspiration and not the other way around. Otherwise you will be causing a lot of traction onto the retina, giving rise to a obvious retinal detachment. Now let us understand the principles of anterior vitrectomy in this case, in which we are actually encountering a posterior polar cataract. So whenever you have a posterior polar cataract, you know that you should actually have a capsular rhexis which should be of the mid size, not too big, not too small, of course. Once it is done, you can also do what is called as the mechanical mechanical dissection, that is you are separating the nucleus, the epinucleus or the cortex from the capsule with only mechanics, but here we are trying to do multi-quadrant hydrodelineation. You must not do hydrodissection as has been taught to us time to time. This is a NS2 to 3 cataract, so basically it is important that you actually don't try to rotate the nucleus, and you have to avoid any kind of forces turning the posterior capsule, causing any kind of traction onto it. So the chopping has to be done in a vertical fashion, and it has to be done in very, very delicate fashion without causing too much of anterior chamber fluctuation. You can see that without causing any rotation of the nucleus, these pieces are being taken out one by one. It is important to fill the viscoelastic time to time without removing your phaco probe and use a dispersive viscoelastic as we have discussed. So now we have almost removed the large chunk of this endonucleus. Once that is done, of course, you have to make sure that you remove the epinuclear plate. So that is being done very, very gently without causing, again, any traction onto the PC. And the viscoelastic has been filled time to time. But you can see now that once we are at the end, fortunately, we have removed the vast majority of the endonucleus and also the epinuclear plate. But when you are at the end, of course, in these cases such as a true posterior polar cataract, you can still encounter a posterior capsular dehiscence, which has been seen here very well. Once you see the posterior capsular dehiscence, the most important thing, as we discussed, is to avoid knee-jerk reaction. Go with your dispersive viscoelastic, and now once the chamber is formed, then only you pull out your phacoprobe. So you can once again see the time when this posterior capsule had opened up from the pre-existing PPC in this case, in this particular case. Once that is done, and once you have your good amount of viscoelastic which is plugging the vitreous on the back, and then you have to use a tricot which is going to basically stain your vitreous. It is also a good idea to make probably one more incision so that you can have a completely fresh entry in this thing. This tricot is actually, now you can visualize the vitreous very, very well. Then go ahead with your vitrector. With the vitrector, make sure that you do a very thorough vitrectomy, removing all the vitreous that has been prolapsed in the anterior chamber and also at the bud, which is at the junction of your posterior capsule and below, so that the vitreous becomes completely dissociated from the anterior chamber. Make sure that you keep filling the dispersive viscoelastic time to time. Once you're sure that your vitreous has been completely cleaned off, you go ahead and you can do a regular IA. Make sure that you do it very, very gently still, and make sure that you're not going to enlarge this posterior capsular rupture. Now this is the viscoelastic which is being basically injected again and again, as you can see. Make sure that you don't even overfill the chamber, because if you're going to overfill the chamber, it is going to cause a more blowout of the PC. You can see it's a very typical posterior polar cataract kind of opening, which is like this, which is like a spindle in shape, as you can see it here. Fortunately, once you have taken care of the vitreous very well, it is not going to enlarge. And again, make sure that you have put in your viscoelastics in place. Always, as we discussed, make sure that you have a 3-piece lens in your library. This 3-piece lens has to be loaded and has to be implanted into the sulcus. And you can see it here, you have to be very, very gentle. Just go below the iris and in front of your very good created anterior capsular rhexis. Make sure that this is being rotated in place. And once it is done, you can do also the anterior capsular capture. You can do a capture of the optic so that the lens remains very, very stable. You can use intracameral pilocarpine at the end so that basically you avoid any kind of even vitreous to come out after that as well. Once that is done, it of course gives you a very, very good outcome. So if your PCR is small, it can be converted into a PCC and you can implant the lens into the back. If the PCR is slightly on the bigger side and you have the intact ACC, as we have seen in the previous case, we can still implant the lens and do a capture. But if you have a larger PCR with a questionable support of the capsule, you also have the option of doing suturing of this 3-piece lenses to the iris. My mentor, Professor Sonia Yu, was a large proponent of that, and I have seen her doing this time and again, and I have done a few myself. And of course, if there is no capsular support at all, then you have options of doing the iris claw lenses, scleral fixation, or the, of course, you should avoid ACIOL in the current times. So to conclude, the PC rupture or the posterior capsular rent is an important complication of phacoemulsification. A careful and diligent handling of PC, early detection of PCR, and meticulous vitrectomy with preservation of capsular support as much as possible is of paramount importance. Understand the principles of anterior vitrectomy, that is the cornerstone of the success of PCR management and your optimal outcomes post-operatively. And the location of the IOL implantation and the design, it will be very carefully chosen depending on how much capsule you have left, and that is going to optimize your long-term outcomes. So thank you very much for your kind attention. Thank you. Thank you so much again, Dr. Kumar. Thank you.
Thank you, Vardhaman. Any questions from the audience, because everybody is leaving for the other instruction courses they are a part of. I'd like to invite Professor Waldemar, who is the president of the Slovenian Society of Cataract and Refractive Surgeons, heads the refractive and cornea services at the University Eye Hospital there, and of course the CEO of the Eye Surgery Center, which it's also a member of the ESCRS since many, many years, and examiner of the EBO Examination Board member, who is going to talk to us about intrascleral IOL fixation. Over to Professor.
Thank you very much for a nice introduction. My talk is about the intrascleral IOL fixation. And if we have no zonal support, what we do is actually all of those things. But I'm going to talk about Yamana and Calabrava technique. We know that Chariot started in 2000, and Argaval came with his good idea of gluing because Chariot had problems with the hypotony after the surgery. And then in 2015, I think, Yamana came with his fantastic technique, and then in 2018, Calabrava. So why Yamana or Calabrava? Because it's minimally invasive, it's transconjunctival and sutureless. It's just like a cataract surgery. It goes with topical, just some subconjunctival at the site of the incision, and we do just 1 3mm incision. No opening of the conjunctiva. So this is my latest technique. We do mark 180 degrees apart and then 2 millimeters behind the limbus. In young individuals, 2.2 millimeters behind the limbus. We bend first needle 45 degrees, the second needle about 80 degrees. Then the IOL is being implanted onto the iris, and the trailing haptic stays out of the eye. We can also capture or fixate the lens using the infusion. This is usually 25 gauge infusion cannula. It has to be there all the time at the surgery, and with the trailing haptic we can adjust the front haptic so that we are able to catch it later on with the forceps. Now, parallel to the limbus, the tunnel is done. It's long about 1.5 millimeters. Then we grab with the forceps. The forceps is held like that. We are not holding forceps like that, but like that. And I'm adjusting my hands. I'm left-handed, so I'm pushing my left hand towards the forceps and docking the haptic about 2 millimeters. Then, this is my innovation. This is put, okay, this needle is on a syringe. I'm taking syringe away because I'm much more precise with the syringe. And now I'm putting this onto the iris. So it's safe here, and I have to do another tunnel on the opposite side with the 80-degree bent needle, and again with the same forceps, holding it like this, I'm docking the second haptic. This surgery can be done in very small pupils, as I'm going to show later on. So docking, if you're starting this, it's good to train the docking outside of the eye. There are different lenses that can be used. In this situation, it's a sensor. And then when docking is done, we're just pulling simultaneously both haptics out of the eye. And then the flanges are done. And actually, this is the end of the surgery. So this is nearly as quick as the cataract surgery. So this is a case. I want to run through it very quickly, where it is really very small pupil. And we are able to do the technique also in such case because we push away with the needle the iris, and we are able to dock. So I've just showed the end of the surgery. Here we are making the flanges at the haptics at the end, and these haptics have to be dry when doing the flanges. We go just nearly 1 millimeter to it, and the haptics changed. And then they are just pushed back into the sclera. We can push it into the sclera, but I want to see them at the end of the surgery. This is another case. We see a heavily dislocated, subluxated lens, we took it out with the capsule, and now we are doing the same technique as you've seen before, pulling out. If we pull out simultaneously, there is very little stress on the haptic-optic junction, which I think is the most vulnerable in this kind of surgery. And now here we are taking also care of the pupil. So we are doing pupil cerclage, and after polishing it a little bit with a Gavov dialer, we have quite nice case at the end of the surgery. So here, this is 12 years after the implantation. The lens was subluxated, and I'm deciding to say that this lens stays in the eye, but I had some bad experiences, so we are laser locking the haptic optic junction. As you can see here, this, when you have tilted lens, you can put it in the right position and laser lock it, and it stays like that. So this is another case. This is a trauma. Vitrectomy was done, and here we have decided to go for the implantation of the artificial iris and the IOL. We will use the same technique as you saw before, the Yamana, and also to put the IOL onto the artificial iris, we use the same needles, 30 gauge needles, on both sides, 0.5 millimeter away from the edge of the artificial iris. And then this artificial iris is implanted through the frown incision into the anterior chamber, and now docking of the haptics is performed on one side and on the other side, just normal Yamana technique, and then both are just pulled out in the same direction as we push them in, and we see nicely centered complex of the artificial iris and the IOL. Then at the end, the flanges are done, as you saw it before, and this is the case then at the end of the surgery. Take some time. The patient's eye, and this is the case 5 years after the surgery, working very good, looking very good. So another case I want to show you here, this is a preoperative, and here we have total iridia. The patient had trauma, and here we are going to implant the IOL and artificial iris using the Canabrava technique. So we have four 60 Prolin sutures that are put through the IOL, through the artificial iris. We are making a frown incision. Now you see this complex, and at first we mark four places, and we bring in the two 60 Prolin sutures. The tunnels should be done not perpendicular but oblique to the sclera, and then at the end we bring this suture out of the stab incision, go in again to be able to bring it out 2 millimeters behind the limbus on this side. And then at the end we cut it away and center the IOL and the artificial iris. With this technique you could implant also the toric IOL, maybe also the multifocal toric, but the effective lens position is very questionable. And then we push these sutures, flanges, into the sclera, so that they are just a little bit visible under the conjunctiva. So this is the case at the end of the patient. And surgical step, I think marking is very important. Tunnel should be limbus parallel, 2 millimeters, with the children 2.3, with the old, with the young man 2.2 millimeters, not to get the optic capture. And it really made this technique my life really, really easier, because I know every patient can go from the table with the IOL in the eye, and we have all the lenses, all the diopters at our disposal all the time. And I'm inviting you to Copenhagen, and thank you for your patience.
That was really fantastic, Professor. I really thought that placing the needle on the side made the life so simple. I've never thought of this, that you can just leave it. You know, every time we're in a hurry to get that haptic out, and then someone holding on to it, or some other assistant holding on to it. But this, I thought, was a brilliant idea. The artificial iris that you're using is made by which company?
Human optics.
Human optics. So it does not disperse any pigment over the number of years and cause any glaucoma or anything?
No, I'm using it from 2013.
Wow.
Results are perfect. This comes with the fiber, without fiber. I'm using just without fiber, and I cutting it down to 10.5 millimeters. It
Yes,
comes
you
12.8. Yeah, I refined it down.
Yeah.
And it should be implanted in the way it doesn't touch anything in the eye. If it's touching, I don't know, ciliary body, iris, in 2-3 years you will have a problem. Cystic edema, the Huck syndrome, it's terrible then.
How do you make sure that it doesn't move? You suture it to the, how do you make sure it's placed well and always remains like that?
It won't move because it's on these sutures.
Yes.
They are stiff enough that it doesn't move. Important is only that you judge where is the effective lens position. And usually I implant the lens of -3 and leave it a little bit behind. And if it is needed, I can bring it in front. And we have intraoperative OCT, so we can judge how deep it is. And also we can look if there is any touch or not at the periphery.
Now, in your country, you will have everybody with light eyes, so they normally have large pupils. Do you have control on these artificial irises with different size pupils? And
No.
if you do not, and if any of them develop any retinal detachment, is it very easy for them the retinal team to manage that, or it's really not a problem?
It's a 3.5 millimeter opening, and it works very well with new systems for retinal visualization.
Thank you very much. That was fantastic. The last speaker, Dr. Gaurav Luthra, who's a dear friend of mine. I was supposed to go to his course, but I had no one here to take care. So, Gaurav, please, last 5-10 minutes, whatever you would like to show. He's got a phenomenal practice. Everybody knows Gaurav. He does a lot of live surgeries all over the country and internationally. He's from Dehradun. He's going to talk about his OOPS moments in cataract surgery.
Thanks, Kumar, and very good afternoon, everyone. And you can see one of those OOPS moments right there, and I'm sure some of these have already been covered during the session. And I wanted to just showcase this one video. I was doing a posterior polar cataract, and I'd done a lot of planning. I like to do a femto-assisted surgery with leaving behind a cushion of about 700 to 800 microns of the epinucleus, and no hydrodissection but a good hydrodelineation. You can see that I'm following all the rules of posterior polar cataract removal. I'm removing only the endonucleus, no rotation, and trying to ensure that I leave a good epinuclear cushion right till the end. So things go well. I'm putting in viscoelastic when removing the instrument from there. Once the nucleus is gone, you can see on intraoperative OCT that everything was in good shape till before. You can see that it's nicely stuck to the posterior capsule. So I don't want a fluid wave to go over here. So I'm going to go on, and now by manual I'll disengage the cortex and the epinucleus from the equator, make sure that on all sides I've debulked the epinucleus shell, so that the last part is the central core which is attached to the posterior capsule, and I'll let it float up with either infusion or with hydrofusion or with viscoelastic. So you can see that I'm not aspirating, I'm just disengaging it, and all this while my posterior pole remains intact, and I'm focusing on that posterior pole. Now you can see a small plane beginning to develop. You can see the plane of hydrodelineation happening over here, so it's beginning to separate. And this is a better way to let it happen, because once that separation has happened, then I can actually aspirate it very easily. So I've managed to do a good job, and everything looks good. You can see that that area is still secure, and I'm now going to implant the lens. The lens is implanted. You see that small area of attachment. Everything is great. I'm very happy that my surgery has gone well. I'm beginning to close up the case, and I'm just putting infusion, and you see what happens. So I did everything right, got everything right. The lens was in place, and all I did was from the side port, I was just closing the eye, and I managed to break them. So in the posterior polar cataract, till your patient goes home and comes the next day, it's not over, and you can get a posterior capsular break at any point. Now this was an intumescent cataract, and I typically like to decompress these lenses. So I'm going with a 26 gauge aspiration to aspirate a little bit of fluid from these lenses and just see what happens. You probably didn't see it happen, but let me show you again. As it went inside, there was a sudden entry, and I created a radial tear in the capsule here. So that was a sudden entry because it was facing some resistance. So instead of creating a controlled tear, I now have, just see that movement happening again. It goes in suddenly, just watch. I should have been stabilizing with the forceps. Now that small movement, it didn't look like much, but it went and created the radial incision, and the cut has gone right till here, beyond the edge of the rexus that I was planning. So anyway, I have to manage it, and I'll go around it. I've created the flap now from both sides, and I will just try to go all around it and see if I can come around. And obviously I'll have to go quite wide, because and in an intumescent cataract, it's not a good idea to go that wide. So under heavy viscoelastic, you can see that I'm a little worried now because it's going a little bit out of control. So I'll have to pull it in. I'll probably try to use a Brian Little's maneuver after injecting some more viscoelastic there. And with that, I'll be able to bring it in and complete the rexus. So it worked out. Sometimes it doesn't work out. This was a black-brown cataract. I was doing a femto-assisted surgery, and I thought I was doing a good job. Everything planned very nicely. It looks beautiful also, almost like a flower over there. It's a very hard cataract. I get the fragment separated, and I'm able to remove the cataract quite nicely over there. But now you can see that the posterior capsule is bulging forward, and I will now go and do a bimanual cortex extraction. So it's a very floppy kind of a bag, and there is some upthrust, and the capsule is bulging forward when the chamber is lost. So I managed to do a good job so far. I'm now removing some of the cortex from all areas. This is a little bit fast, but now just see what happened. I caught the bag, and in that, I didn't do the surgery this fast, but I've caught the bag. It was just fast forwarded for you to be able to appreciate what was happening. So I've got the bag, and now I've used reflux, and I've switched on the infusion, so things are looking slightly better. But now I'm in a situation. So in that situation, I forgot that I have to inject viscoelastic from the side port. I just came out, and now just see what's happening. There is that upthrust. The bag is crumpling to one side. I quickly panic. I push in viscoelastic, but that makes it worse. Now the bag has gone towards 6 o'clock. Half the bag is gone. Now I realize that I should have pushed in viscoelastic. So this was a big oops moment. I should have put viscoelastic from the other side port and inside the bag to inflate it, rather than push it from the main port and try to, make it like worse than what it was. So essentially now I'm in a situation, so I'll manage it. I'll put in a CTR, and I'll probably be able to save this eye. But this is something that you should never do, because it can cause a problem. A very similar situation to what this was in live surgery in Amritsar. I was getting ready to do the live surgery, and everything looked very nice, and I'm all set, and I have a few people standing aside, and I'm going to make my first incision. So there I'm going with a side port. I like to make my side port with angled side port knives. I was given a MVR and just see, I've created a small nick over there, just like in that first case. So this happens in live surgery quite often because you're using instrumentation which is not to your liking and what you don't use routinely. And I never use these MVRs, and this is a straight MVR which is very unorgonomic. So anyway, once you're in this situation, now I had 3 people around me, and if you look on the top side here, you'll suddenly see 3-4 stalwarts hanging around me, trying to guide me how I should manage this. Amongst them Dr. Kumar and Dr. Rohit Prakash and Dr. Mahipal, I remember, were all around and trying to give me tips on how to handle this. So we thought of several things, but there was no consensus on what we should do, because getting around it was looking like a very unlikely task. So we eventually went in and created a rexus which was separate from that nick. So I've created a small rexus, and I've not gone into that area at all, and I've left that untouched. So I will be able to complete the surgery from this new rexus, and that part will remain like that. So this was a new thing that I learned in live surgery, was that you can still manage it with the nick, and you can see that I've managed to get the cataract out, and that nick remains undisturbed right till the end. And then eventually I put in the lens, so things go smoothly over there. So I think I have a few more, but we've run out of time, so I'll just stop here. Thank you so much for giving me an opportunity, Dr. Kumar.
Thank you, Gaurav. Any questions? I think that case I was there when he did this, and that you saw that nick. Normally we panic because, and to his luck or his good technique, the CCC did not join the nick. Otherwise, if that joins the nick, it can still further go ahead and touch the equator, and worst case, it can go around and have a problem and nick in your posterior capsule. Would you like to say something?
Yes, it is good to have sharp instruments. Otherwise, you're pushing the eye. And what I'm doing, I'm putting a finger here. Counter pressure.
Yeah.
Yes. All the time, with main and with step.
True. So, of course, all of us, we are used to either an MVR or a side port, whatever you are all used to. But all these things can suddenly happen in your surgery, and it can suddenly surprise you, but this is just a quick tip as to you can still manage these tough cases this way. Thank you all very much, and thank you to the panel. Course ends now, and now we have Chitra's instruction course in this same hall.